Good afternoon, everyone, and thank you for joining us for this session from Ambition to Impact, delivering the future of cancer care. We have an hour to hopefully have some fantastic discussion amongst our panelists and to make sure that we take as many questions from you as possible. So before I hand over to panelists to introduce themselves, just a couple of words of intro and housekeeping. We have had, since the general election, a year of policy development and strategising, culminating in the publication of the 10-year health plan in the summer. That talks about some fundamental shifts in the way care is going to be delivered, hospital to community, analogue to digital, sickness to prevention. And we're also awaiting and expecting a new national cancer plan before the end of the year. And we expect this to be the first disease national plan since the 10-year plan has been published. So a really good opportunity to think about how to bring the shifts to life and how to outline the ambitions set out in the 10-year plan, applying them to cancer. We have made great strides in cancer care over previous decades. In the UK, our cancer outcomes still lag behind the best performing countries in the world. So an opportunity to look forward, discuss the forthcoming cancer plan in the context of where we are now. We are going to take questions from you, so please submit questions via the Q&A tab at the top of your screen. You can vote for your favourite questions by upvoting them using the upwards arrow next to each question. And we also hope you have had or will have the opportunity to visit our resources provided in the joining instructions ahead of today, which cover some of the issues and topics we'll discuss. And this online event is funded by MSD as sponsor, with one representative from MSD participating in the discussion. MSD has had no input into the meeting agenda, speaker selection, or other panel arrangements. Editorial control of the content remains with the King's Fund. So over to panelists now, and I'm going to ask you to introduce yourselves. Can I start with Mike?
Thanks, Sarah, very much. Mike Richards. Many years ago, I was an oncologist, and then I was National Cancer Director. More recently, I chair now the National Screening Committee, but I've also had a major interest in diagnostics as well. So that's probably me.
Wonderful, thank you. Leeanne.
Hi there, my name is Leeanne Graham. I am the advocacy lead for the UK-based charity Black Women Rising, which supports Black women and women of colour going through a cancer diagnosis and treatment and life beyond. I also have lived experience having had breast cancer myself. Thank
you. Adam.
Thank you. Good afternoon. My name is Adam Januszewski. I'm a medical oncologist based at St Bartholomew's Hospital in London. I co-manage our research delivery team, have various different hats, but also have an interest in overcoming barriers of access to cancer treatments.
Thank you. And Urmi.
Good afternoon, everyone. I'm Dr. Urmi Shukla. I'm the Head of Medical Affairs Oncology at MSD UK. MSD currently has over 40 active collaborations with the NHS and with cancer communities. And being a biopharmaceutical company, we can offer deep insights into the systemic changes and the opportunities and challenges for patient care.
Lovely, thank you. Fantastic panel. So if it's okay with you, we'll get straight into our first question and discussion topic. And it really centres on the 10-year plan and what we think this means for cancer. So when the 10-year plan was launched a few months ago, I'm really interested in what struck you as the key opportunities and what questions did the plan raise for you that you think the forthcoming cancer plan has the opportunity to address. Mike.
Thanks, Sarah. I mean, clearly the three shifts were central to the 10-year plan. Prevention being the first one of those, then the shift from hospital to community and analog to digital. But let's start with prevention because and prevention has lots of different meanings here. There's primary prevention, and it's estimated that perhaps 40% of all cancers could be prevented if we didn't smoke, we weren't obese, we didn't drink alcohol, dealt with air pollution, whatever. So there's lots that can be done there. But there's also prevention in terms of early diagnosis, and this is a real opportunity for cancer, preventing the complications of having late stage disease, and late stage disease being what kills people. So can we do screening better? I think we can. We've got a limited number of screening programs at the moment. There are other things in the offing. You know, could we do breast screening better? Can we do cervical screening better with self-testing or self-sampling, for example? Should we be screening people with breast cancer who've got dense breasts more actively than we are? And certainly with bowel screening, which is a very successful program, but at the moment the threshold is much too high at a fit level of 120. We need to bring that down. But quite apart from that, there are other new things in the pipeline. We've got difficult decisions to make about prostate screening, which will come to the National Screening Committee shortly. But then in this next year, we're expecting results from the NHS Gallery trial on multi-cancer detection. So all sorts of things there. And then that's even before we get on to patients with symptoms, where we need to be, I think, helping GPs in particular with how to triage and how to identify the ones that are most likely to have cancer. And then even later down at preventing people with cancer having acute admissions, you know, so it's across the spectrum. We can prevent the problems that are related to cancer. So that's where I would like to see a lot of emphasis in the cancer plan.
Thank you. And I'm sure we'll return to a couple of those themes. Leeanne.
Hi. So we think at Black Women Rising there are loads of opportunities to really kind of understand how we as a peer supporting charity can use the 10-year plan to make sure that we're able to really support our members and those who are going through a cancer diagnosis. The sort of patient-powered healthcare aspect of it means that patients are going to be able to have more access to more information to make their choices, the digital tools that might come into usage to help navigate their care, and the agency for people to really manage their own health and treatment, which are fantastic. But actually, we also need to consider those who might then be left behind by those changes, those who don't have access to digital tools the way that many do, patients, especially who are older and in more deprived areas, and there is a risk that these changes are going to widen those inequities unless we kind of keep the human balance. And I think that's one of the concerns that I have with digital poverty and all the changes that they're hoping to bring into use. How do we really make sure that nobody gets left behind? So for us at Black Women Rising, it's also really important that we keep the peer support element, we keep that human element, and we work collectively as a community of charities, grassroots charities, who are able to be there on the ground and make sure that the changes that are trying to be implemented work for everybody. We want to make sure that we are able to feed into the changes that are coming in a way that allows us to really put forth the experiences that people who are living with cancer deal with daily, and make sure that they're implemented within the plan so that we all have the opportunity to benefit from everything that's coming in.
Thank you. Adam.
Yeah, I mean, there's so much there in the 10-year plan. I think anyone that works in the health system at the moment knows the pressure that everyone is under. And I think one of the important parts of this is the new models of care and community and neighbourhood care, because while there have been moves to bringing care close to home, you see blood tests being in the community, appointments virtual. We're now starting to allow patients to give self-administration of some anti-cancer therapies. Is that we really need a further drive for this. It's good for patients, it's good for the health system, because ultimately with such pressures in our kind of tertiary and secondary and tertiary care, that we really need to help improve capacity for some of the more complex and advanced therapies that are on the horizon. So there's many benefits of bringing patients care closer to their home through the use of neighbourhood or community centres. So that's one of the things, as well as obviously the big technological revolution, but I'm sure we'll talk about that later.
Thank you. And there's certainly a huge amount of energy around the neighbourhood conversation, what exactly it means. I will come to that very shortly. But first, Urmi.
Yeah, thank you. So we really welcome the ambition that's been set out in the 10-year health plan, especially around genomics and precision medicine. For the cancer plan to be truly, have that patient impact, I think that there is also this conversation around now and then the future. When we think about the future, if we think that there's probably around 2,000 products at the moment in development for cancer care, around half of them, around 50%, are expected to have some sort of companion diagnostic, and that could be in the form of precision, a biomarker test or a genomic test. So really, we're very aware of the challenges that this could bring. So this could add to the top of the funnel and really sort of not help already the challenges that we're seeing around turnaround time and testing and access to medicines. But this could also be then an opportunity perhaps to have a look at the existing horizon scanning, and maybe for that to evolve to really give that forward future thinking lens.
Yeah, thank you. This idea of how ready is the system for the innovation that's coming is clearly critical. Thank you all. So I want to dig a little deeper into a couple of the big themes outlined in the plan. And I'm going to start with this focus on neighbourhood health, which is everywhere. I've just come back from party conference season, and there's so much energy around this conversation. There's also rather a lot of different interpretations of what it could mean. So, Mike, what do you think neighbourhood health for cancer could look like when at its best?
Well, I think we're already on our way with this one, in that over the last 3-4 years, we have been developing community diagnostic centres. Maybe we'll need to rebrand them as neighbourhood diagnostic centres. I don't mind that, but community anyway. We now have 170 of those across the country that are up and running. But why did we go for that model? We knew that we needed more diagnostic capacity. We also knew it's quite difficult to put that extra diagnostic capacity into hospitals. They are very crowded places, and hardly any hospitals in the country have spare parking. So they're not always convenient. So why not bring a community, the diagnostics closer to people's homes? And we defined what sort of things we would expect to see in those. But the model is now moving on, and I think rather than just giving extra capacity in the community, it is how can we change pathways? And so people who've got postmenopausal bleeding and things like that, how can we best investigate those? Do they all need to go onto hospital, particularly if the sort of postmenopausal bleeding on HRT? So there are lots of things, and I can take you to community diagnostic centres that are now doing the lung pathway, the head and neck pathway, the non-specific symptom pathway, and the more the merrier as far as I can see, because actually that's also going to help us to achieve the 62-day target, which we've had for the last 20 years or so. But I can point you to one community diagnostic centre where the patients that come through the head and neck pathway in the CDC, they do achieve the faster diagnosis standard. Those that go through the rest of the trust do not. So there's evidence there that we could do a whole lot better.
Thank you. I mean, that's excellent. Having been and visited a couple of them, can attest to some of the great stuff they're doing. Can I ask a very brief follow-up question, which is, how much active conversation is there about really expanding the reach of almost what you could put in a CDC? Some of the neighbourhood conversation is around this join up of health and social care and different types of support and services.
I think there's huge opportunity, and I think now that we've got the 10-year plan, that will be given prominence. when the CDC started, they were purely about diagnostics. They're now also beginning to be about diagnostics and simple treatments, which is a good start. But I think you're absolutely right. The link up with social care should be there. The single point of access for patients could be run from a CDC. There are all sorts of opportunities, and now is the time to get thinking about that.
Thank you. Urmi, I'd like to bring you in on this. You have a perspective on neighbourhood health, and I know you've got a couple of examples where your work has supported and provided insights into, what great neighbourhood cancer care might look like.
Yeah, and Mike's already mentioned the 62-day, waiting time standard and how this has not been met for a while. So, when we're thinking about having that delay, having that wait in the system, we know it's really a really anxious, stressful time for patients already. And then there is this additional delay to, maybe reaching the optimal treatment for them. So collaboration is key here. There are, the collaboration offers a chance for really us to bring our skill set to the NHS and work with the NHS and support them. So an example is a project that MSD has done with Oxford RED. So RED stands for the Respiratory Early Diagnosis Service. And this was a collaborative working done with the Oxford University NHS Trust. And what this led to was an earlier diagnosis, time to treatment for patients with lung cancer, and reduce the time in the pathway to getting seen and getting treated by 15 days. So this is a really example of which we're really proud of, which has led to earlier time to diagnosis and treatment. Additionally, this can then be shared with other cancer alliances as best practice.
Fantastic, thank you. Really great to hear case studies that sort of brought to life to make it feel tangible. I'm going to move us on. So the digital and tech shift, which is at the heart of the government's plans, and a key enabler of productivity, as well as patient experience and outcomes, which you talked about up front, Leeanne. What's likely to make it most successful? What will get in the way of making fast progress in this area? And can I come to you, Leeanne, first, because you did touch on this, the ability to drive improved patient experience, but make sure we're taking everyone with us.
Absolutely. So I think what's really important to recognise is how are we going to make sure that the support that is given via the tech shift is, one, accessible to everybody, two, that is understandable, that is integrated across every area. So for instance, talking to my doctor and talking to my chart, they don't connect up. They're on two different systems. So if we're proposing to bring in so much technology, how are we going to make sure that everything is married up in one place and is working effectively, especially, as I mentioned before, for those people who aren't tech savvy? I'm someone who uses technology every single day, and I find it confusing. I get several text messages, I get several emails telling me to go to various different places. So it's really important that we put this technology in place in a way that's accessible for everybody who needs it. And also, what then tends to happen is we put a new technology in place, we expect everybody to understand it, and then the shift, when things go wrong, the blame shifts to the person, the user, who is not used to this technology. Oh, well, they haven't used it correctly. And I think that's a really upsetting position to put people in when they're already perhaps confused, upset, and going through difficult times, to then have a technology that they don't understand, because we don't get training given to us as patients. We just get told, here, use this particular piece of software. So understanding how we can empower people, but also protect them to make sure that they're getting the best of the technology, making sure that it's flexible, making sure that the technology is personalized and it doesn't just make us feel like a number anytime we're opening up a new app. How are we going to ensure that we're getting buy-in from the people who are using this tech and it's working at every single level? So where's the accountability? Making sure that it's innovative and inclusive, and also the important question around data protection and data ownership and where that information sits. It's really important to me as we move into a very digital age that we don't lose our empathy and our efficiency. There has to be a really fine balance. I understand that we want to use technology for the best possible way when it comes to our health, but actually, are we forgetting that person-centered care is the best way forward always. And by bringing in this technology, does that absolve some services of having that person-centered care? So I think when it comes to Black Women Rising and the work that we do, we want to be on board with as many of the systems as possible. I think that the government should be working with organisations like Black Women Rising, like the bigger cancer charities, to ensure that we're able to support as many people as possible by making sure that everybody at every level can use this technology. We can't just put it in the hands of patients and expect them to understand what's happening. It has to be communicated very, very clearly. And if we are unable to use that technology as patients, how do we continue to get the help and support that we need to make sure that our care is given to us in the best way? So those are the thoughts that are going through my mind when I think about the tech shift and how we can make sure that it really works. I don't have the answers to these, but I think it involves sitting down with charities, sitting down with organisations, sitting down with the people who are going to be using it, and ensuring that everybody has a really great understanding of how it benefits us, if it benefits us. Let's also not just stick with technology because we think it's the best thing when it's clearly not working. If it's not working, there have to be backups in place. There have to be other opportunities and flexibilities to make sure that we are putting in place something that works.
Lovely, thank you. Incredibly powerful. Adam, can I come to you on this one? And I'm particularly interested in, the opportunity, but also some potential challenge for clinical teams, for staff of this shift.
Yeah, absolutely, Sarah. And I agree with Leeanne. Any technological revolution or progress has to be for all health literacy, whether that's patients, but also staff as well. And this is the only way that the NHS will succeed, is by embracing technology, ultimately. I mean, I think we all understand that the majority of healthcare providers use electronic patient records these days. Now, it's undoubtedly delivered safer care, but it has its challenges, as you will find if you speak to anyone that works with it. Yes, we don't go around finding hard copies of scans anymore, but some things like in outpatients take up to 2 minutes using the tech, which previously when you used paper would take 10 seconds. So I think there's real opportunity to streamline the process by using technology. And there's massive opportunity here. I mean, obviously we've got potential for using AI for some administrative staffs, administrative tasks that we do. There's a whole single sign-in, which would save lots and lots of millions of hours of clinicians' time, and indeed others. I mean, there's the AI used to help, for example, plan radiotherapy or to look at images, either scans. So there's lots of things, and to bring into cancer around PROMs. We've known for years that digital PROMs improves outcomes, and yet there's been a piecemeal approach to it, and we haven't embraced that. So there's lots there, and I suppose what we do need to do is progress with that. But what you need the hardware, because that's a key factor. And it sounds simple, but we can't do that without the hardware. Then we need the software, and then we need tech-enabled and a workforce that is able to use and innovate and embrace these things. And I suppose the last thing, is what I see when I look across the country is a lot of people working in silos. You've got 10 different apps that all do the same thing. And now, while the market is healthy because you can innovate in that way, I feel that there needs to be a little bit of leadership that may come from, hopefully, the cancer plan that really that helps drive forward embracing the technological revolution, while not everyone working independently.
Thank you both. And I think a really strong theme about being honest about what it takes to deliver this kind of change, the time, the training, taking people with you, some of it's fantastic, some of it's maybe not so good, and all the rest of it. Wonderful. I'm going to move us on, and I can see some brilliant questions coming in from attendees of the session, so please do keep them coming. But I want to touch on a theme we're talking about a lot at the King's Fund, which is how you make change happen. So recognizing that quite a few of the ideas in the 10-year plan aren't terribly new, and we have made some wonderful progress over the years, but perhaps we haven't wholesale solved our problems, or there's much more we can do. What is it going to take to make some bigger ambitions a success? and what can we learn from previous cancer plans, previous really positive shifts to kind of take with us into this next phase. Urmi, can I come to you first?
Yeah, so the cancer plan, we want it to be ambitious, but it has to be actionable, to the point you've made, Sarah. And I think for us, it lives in probably two big pillars, right? One of accountability, and then the other one of ownership. So from an accountability point of view, there has to be really clear timelines, really clear understanding. And I suspect that with the upcoming merger of NHS England with the Department of Health and Social Care, there's also going to be a real need for that accountability and for the robust implementation of the plan. And then secondly, there's a piece around ownership. So it'd be great to keep the knowledge and the leadership that we already have with the Cancer Alliances and the National Cancer Programme team within the cancer plan. And, Cancer Alliances seem to have this really unique position in which they understand the local need and can really bring that innovation to the patients who need it.
Lovely. Thank you. And Leeanne?
Yeah, so I've said it again and I'll say it again and again and again, working with organisations, working with the people on the ground is going to really, really help us advocate for our patients and provide that accountability, because we're here. We at the bottom, and I say at the bottom, at grassroots organisations, have a really unique view that those in government aren't going to see. We see the day-to-day impact of the changes in policies on the patients. We see how difficult it is for some of our members to access care. We see when things are going wrong and we see when things are going right. So I think it's imperative that those in control of the plan are listening to those of us who are down here doing that work every single day. We want to make sure that we're kept in the loop. It's important to use charities such as Black Women Rising to collaboratively, can't even say the word, work collaboratively and to connect with the community all the time. You can't just look at this from a top level lens. You have to be there. You have to be on the ground every single day, assessing and reassessing, is this working? Who is this benefiting? Who is this not benefiting? And how can we ensure we're reaching everybody? So I think accountability, who's going to own this? Who's going to make sure that people are being listened to? Who's going to take ownership of when things are going wrong? And we want to help support those actions. We want to help support that accountability so that we can continue to make changes happen. We stand steadfast in peer support and how important that will be, especially when it comes to the neighbourhood health services and the community health services. But we need support from those higher up. Money is always key. Money is always important. And that's going to be really, really helpful for making sure that organisations like ours are continuing to help hold people to account, but also give that support, that further support as it's needed within our communities.
Thank you. Mike, lessons from previous reforms. I think both cancer, but it's interesting because you've held such a range of roles, maybe interesting lessons from other conditions, disease areas, or other things you've worked on over the years.
Thanks. Well, I'll particularly focus on the cancer ones, but yes, what probably people don't remember is that I also at one point chaired a cardiovascular outcome strategy, which was fascinating because I knew very little about it, but by marshalling the relevant people, and I think this is really important. We've got to get this sense of momentum on cancer, and as both Urmi and Leeanne have said, we've got to have bottom up and top down. It's getting that combination right. I think the Cancer Alliances engaging with clinicians and managers and the patient voice at a local level is absolutely vital. We had cancer networks to begin with, which was successful. Then they were disbanded. We then had to reinvent them as Cancer Alliances, which was fine, but I mean, wasted years when we didn't have them, in my view. But at the same time, you do need leadership from the top. You need a national cancer program, in my view. You need really good measurement metrics. One of the things I'm pleased that I wrote into the original cancer plan was that there needs to be an annual report on progress. We need to know what metrics we'll be looking at to see that progress, because ministers, and including the Prime Minister, will want to know that this cancer plan is working. So I think that combination of top down and bottom up is what I would be advocating.
Fantastic, thank you. Adam, finally to you. What do we need? What are the ingredients for best success? Anything you'd like to build on?
I think it's really important that, the NHS and cancer is always under the spotlight. And there's a lot of people that talk down what the NHS does, but yeah, it has been very successful in a number of programs. And sometimes looking at those, we can then understand where we can move forward with the 10-year plan. I mean, when we look, I working look after patients with lung cancer, and that is the disease type with the highest amount of inequality. So forgive me if I have a couple of examples around that, but for example, lung cancer screening, we've adopted that. The estimate is that we've done 3 times as many scans as the whole of Europe, and we are reaching some of those individuals that are least engaged in healthcare. So I think these kinds of things we need to celebrate, but also look and see how we do that. They were largely delivered on being delivered through the alliances. So it's things like that, and there's other cases like we are the first country in the world to have a liquid first approach for patients diagnosed with lung cancer. That's great, and that again has been innovative and sharing best practice. So I think those are a couple of things, as well as kind of the genomics hubs, the vaccine and the cancer vaccine launch pads. These things are all things largely delivered at scale because the NHS is a large organisation, and being able to drill down to that data, sharing data collaboratively, allows us to track progress, improve efficiencies, guides our policies, and ultimately gives us our KPIs. But a lot of that is being delivered, as we've heard from the other speakers. It's about accountability, it's about leadership, and the alliances are very a key in terms of helping share best practice and helping drive that change.
Thank you. I think that's so important to consider what we have done well, the progress we have made. I mean, lung cancer is such a fantastic example of, progress in a relatively short time frame. Okay, I'm going to go to questions, and we are being bombarded with excellent questions, and so I'll do my best to sift. I'm going to take a couple together because they touch on similar themes. First of all, so there's a very popular question: where do you see psychosocial support sitting within the new cancer plan and priorities? How can we ring fence funding for this when we have so much emphasis on screening, diagnostics, and treatment? Can we prioritise thriving rather than just surviving? And there's a related question in a way, a lot of focus on screening, early diagnosis. How can neighbourhood care support people living with and beyond, and its treatment, particularly with psychosocial needs? What are the opportunities for prehab, rehab in the community? So there's a lot in there, but the themes around psychosocial care, giving people, the right holistic support, and recognising this big shift to neighbourhood. How do we make sure that's sufficiently well-rounded? Leeanne, do you want to come in on this first?
So just really thinking about how important community was for me going through my treatment, and how much I see this within the Black Women Rising community, which is when we get together in a room, whatever stage of our treatment we're at, whether we're at diagnosis stage, active treatment, or beyond, being with community helps so much. It helps in terms of toolboxes to navigate the next stage. It helps in terms of having a community of people who are going through similar things as you. Not everybody has the same diagnosis, same treatment plan, but knowing that we're not alone. And when we talk as well about how we're going to integrate these changes, how we manage community taboos, how we manage making sure that people within our community are going for their checks, are understanding the changes that happen to their body, and when they should go in and go to the doctors. So what's really important for us is ensuring that whatever happens with the plan, there are avenues there to really boost the community aspect outside of tech, outside of policy, And again, bringing forward the human in all this, bringing forward the people who are going through these changes. So I think there are real opportunities for the plan to involve neighbourhood and community organisations that are going to make sure that the message on the ground is received by the people in the community. And when it comes to how it can help with our mental health, how it can help manage how we live beyond how we thrive, making sure that those organisations are fully able to support those who are coming through their doors, making sure that there are spaces for people to meet regularly, whether that be online, whether that be in person with coffee mornings, making sure that we're making use of resources such as Future Dreams House or community churches. So we've got loads of community spaces near us, but are they accessible for cancer groups to join? Are they accessible for people who are going through treatment to get in there? Have we got community doctors and community nurses who are able to come to these groups and talk to people who are going through this and help them understand what's available for them? So I think putting those avenues in place is going to be really, really important, because being in community when you're going through the darkest time in your life is something that's really going to help you get through things outside of appointments, treatment, scans and results. Having a community around you who are going to support you with that.
Thank you. Very powerfully points powerfully made, and I think it's, you know, it cuts to prioritization, doesn't it? How do you ensure in a national cancer plan sufficient attention is paid to this agenda? If it's okay, I'm going to move us on because I want to squeeze in as many questions as I can. And Leeanne, you answered that so well. So there's a couple of questions about data, which I do think are interesting, and confidential handling of really sensitive information. So one from Jamie Wood: I see patients who have found out they have cancer by reading it on their NHS app. We know how this information is delivered is important. How can we prevent this? And then another question, Hannah Marder: how do we balance the drive to make patient records and results open to patients with the need to communicate bad news sensitively? Adam, can I come to you on this issue?
Yeah, I mean, it's so important, isn't it? And similar to, I think, what Leeanne said earlier, the use of technology can't get away from patient-centered care. And there's something about, I always think about when I look to maternity, when individuals are given their notes, previously paper notes, and they owned them. And there's something about taking ownership of their illness and being proactive, and that drives change. It drives progress, and so I can understand the importance of essentially having access to your digital records. But yes, there are risks, and it's not right that we're kind of going, I think, in a relatively piecemeal approach with the patient records. You've got different providers, and then you've got different that have implemented different ways of how patients access their records, when the timeout is in terms of getting access to some sensitive information. There isn't an easy solution, and that's obviously why we're talking about it. But I think ensuring that data is clearly confidential is our number one, and it's only shared with the individuals that absolutely require that information. But there's not an easy fix for that.
No, thank you. And Urmi, do you want to come on this? You know, come in on this one. On the one hand, there's fantastic opportunity to use data to further development of innovation, treatment, and to give information more quickly to patients. On the other, the risks and challenges.
Yes. So I think all the points around patient confidentiality and the need to be really mindful with the data, and there to be a process has been covered. I think the other aspect is around collection of patient level data and how we use that. And an example of this is around work that has been done around triple negative breast cancer, and how we know that the progesterone receptor status isn't always captured in the NHS. And so we don't probably truly understand the number of patients with this condition, and therefore we probably can't then make sure that we have the capabilities and the services and the right number of people to look after these patients. So I think there's a real piece around making sure that the data that is collected is accurate and is then appropriately shared and kept confidential.
Thank you. Mike, an early diagnosis and staging question. NG12 is now 10 years old and early diagnosis staging has only improved a little, mainly due to lung cancer screening. What are your thoughts on using AI to mine the wealth of data in primary care records to risk stratify and investigate patients earlier before they present to the GP, often at a later stage? I mean, that's quite a specific question, but you can feel free to broaden. But how do we go further, faster on early cancer diagnosis, improving staging?
The first bit of good news is that actually everybody now does agree that early diagnosis matters. You may think it's surprising, but I can tell you that 25 years ago that wasn't the case. I was banging the drum, but I had to bang a drum, and I now don't. So that's good. We could do a lot better on screening. At the moment, screening only picks up about 6% of all cancers. I would love to see an ambition to double that or triple that. And with new screening technologies, I think that could be possible. We need to get the evidence first. I think you raised the question of how can we support GPs. It's a very difficult job in primary care to sift out who are the ones that need to be sent on and sent on urgently. So better triage tools. I think AI can come into this. There's an organisation called See the Signs. It may not be the only one, but they use information that's already in the GP's computer, combined with what the current symptoms are now, to help identify who might need to be sent on, and that can also help with the so-called Jess's law. 3 strikes and rethink, and just prompting the GP that this person has come 2 or 3 times, and so therefore let's have a rethink. So there's a lot I think that can be done there. Getting people through diagnosis faster. The 62 days, we always knew that it was the 61 nights in between that was the real time of anxiety. So that remains true. But we now also know that actually delays then do affect survival. So we've really got to get back to the 62 days. I realise that's more difficult now. There are more people being referred urgently, which is in many ways a good thing. But and there are more tests that we need to do to get the patient to the right treatment, and lung cancer is a very good example of that. But that doesn't mean we shouldn't do it, and I think that's where we really need to challenge ourselves on changing the pathways to diagnosis and treatment, and we've got to be bold. And do things differently, and online consultations which are now being talked about, the online hospital. This can work. There are individual independent sector providers who are already doing this and demonstrating that you can get people being assessed within 48 hours and then into the whatever diagnostics they need a whole lot quicker. So we need a combined approach of all of those things, from helping the screening to helping the GP to getting them through the hospital system faster.
Fantastic, thank you. I've got a treatment question here from Spencer Goodman. Operational performance in radiotherapy has declined, with services reporting long delays for patients needing treatment. However, this generally does not receive the same level of visibility in the public debate as chemotherapy and some other cancer treatments. We are high-tech based and underfunded, so important to focus on what already works. I mean, you could take that question in a few different directions. Adam, how do you want to take this one?
Yeah, I mean, it's an issue that we're hearing from across the country, and the lack of capital in recent years to upgrade to the latest technologies has been an issue, with kind of machines coming towards the end of their kind of their lifetime. I'm not sure. I think in terms of, I think we are aware of these issues. It may not make it into the kind of the news press kind of areas, but I think that we are aware of them, and ultimately it's about that kind of medium to long-term planning, which is sometimes challenging as technologies change quite quickly as well. To get the best kind of radiotherapy machine costs a large amount of money, and you need kind of that medium term kind of business cases to be able to deliver that. And certainly we know not only radiotherapy machines, but in terms of diagnostic scans, we have far fewer than kind of comparative countries in Europe. But I think it's part of the package, isn't it? It's not just the systemic therapies, it's the radiotherapy, it's the surgery that need to be taken, and it's that collaborative approach.
Thank you. I'd like to turn to a question on research and linking it to neighbourhood and communities. So really interesting question from Michelle Chen. How do you envisage cancer research moving into neighbourhoods, bearing in mind regulatory governance, and what does the panel think we should be doing more of to prioritise involving people and communities underrepresented in research? Urmi, do you want to take that first? I mean, it's interested in your perspective about, where you're conducting research in a changing world with this ambition to try to deliver care closer to home.
Yeah, so I can speak to, from our side, and I think, Adam, you've got really, really great experience as well, and some of the collaborative work that we've done. Ideally, we want the clinical trial population to reflect the real world population when when licenses are granted for products. So for us, any work that can be done, and the question mentions sort of within the regulatory framework that we have at the moment, we will try to get as diverse a population as possible. So I think there's an element around awareness, and what can be done there to make sure that there is awareness at the local level with general practice, and then in the secondary care setting as well, around clinical trials, the option of clinical trials, and then conversations that need to be had. I think there's also a cultural difference, potentially. Different people will have a different threshold for wanting to be involved in clinical research, and I think there's a lot of work that we could be doing there as well, to have these very open, transparent conversations, what clinical trials are, what it involves, and conversations such as that. But yeah, I think, Adam, you're really well placed, considering your experience and where you're based.
Well, Adam, do you want to come in briefly, and then Leeanne, I'd really like your perspective on this question.
Sorry.
Yeah, I mean, St Bartholomew's serves the whole of East London, which is one of the most diverse borough in the country. So we see this day in, day out, and it needs to be a national priority, because our trials don't represent well enough our communities. But there's not a single solution to this, and it's ultimately multifaceted. In terms of the 10-year plan in the neighbourhood, I think there is an important role, but it just depends around the governance of what the neighbourhood centres, what governance they sit under. Because if they were partnered with a trust, then it may be that we can then discuss, because there are things within trials that need to be done in bigger centres, because they are more complex treatments, the way they are made, etc. I'm talking about systemic therapies, but there are many things within trials that can be done in neighbourhood centres, whether that's consultations through the screening part of a trial, whether that's blood tests, whether that's follow-up scans, etc. But there's something about partnering with the centres. We already have, in other countries, you have like hub and spoke models, where the recruitment centres are often in the patient's community, and that we see that we have increased recruitment from individuals from diverse and deprived backgrounds. But I think there is a role, but I think it does need probably think again around some of those governance structures if we are going to really make a difference with this, and maybe this is part of the opportunity for that.
For the plan. Lovely, thank you. Leeanne, do you want to come in on this?
Yeah, I really, really agree with everything that Adam has said, and I think it's really important that we are going into spaces where we might not usually go to get the data and the research that's needed. We know that people from Black communities and communities of colour are not going for screening, so it's important that we figure out how we can reach them, and if that's through hubs and centres that are placed in areas like I'm from in South East London, where we can get the conversation going. It's where we can find, what we need to do is we need to get organisations and money and people talking all in one kind of go, really. There needs to be space for these conversations to happen. And I feel like I'm repeating myself, but it has to happen with the organisations that are already there. It has to happen with the groups that are already there. There needs to be collaborative effort at all levels. And that's how we're going to reach the people who aren't being reached. That's how we're going to get to know who really needs that support from the people who are here already.
Thank you.
Can I come in briefly on this one?
You can, and then I'm going to ask you a question about the workforce. Come in on this one briefly.
This one, just remember, we need very broad research. It's not just about new treatments. And I think, as Leeanne was saying, research into how to increase the uptake of screening, research into the psychosocial aspects. Exercise is one of the best treatments for cancer. How do we get people to take exercise? It's very cheap. It would pass nice any day of the week, but we've just got to get it done. So all of those things are probably going to be better done in the community.
Very good point. Thank you. I did want to, we're running out of time and there are so many good questions. But Mike, can I ask you a question about the workforce and maybe partly with CQC chair hat on? How do we ensure we have a workforce ready to adapt to the changes in the plan when they may be burnt out, under-resourced, and roles and responsibilities are becoming blurred or they're changing?
I think it's also in trying to help a burnt out workforce, and the workforce I'm quite sure is burnt out, to see new opportunities and to see that actually we may need to change the way we do things. And that's difficult. But that's where, going back to the Cancer Alliances, going back to working with the clinicians at a local level, saying actually this can be done differently and can be done better. And so, but that requires a whole lot of engagement to help people see that. So I think it's doable. I mean, going back 25 years, why do people need to work in multidisciplinary teams? You know, there was a lot of angst about that. We now need to move that on and say, how do we get multidisciplinary teams to work best? But you know, and we'll do that through engagement and ultimately by showing people that they can do a better job for their patients, and that because that is what motivates people in the end.
Thank you. I'm going to ask you all a final question, but there's just a very straight, hopefully simple question to ask in the chat. Is there a centralised place where we can learn from what is already happening? For example, the CDC head and neck pathway. So lots of good practice examples. Where can we direct people to for more information?
Well, on that one specifically, the NHS England diagnostics programme, I think they've got a lot of information on the CDCs, and I would refer people to them and the work that's being done across a whole range of different pathways that can be implemented. So, but it's the one place, because the CDCs are not just about cancer, so but they include cancer, which is very important.
Thank you. So I'm going to ask you all a final question, and I'm sorry that we haven't got to everyone's brilliant questions in the chat. We will capture them, and we will have a think about how we can come back to people and reflect themes that have been raised, but we have touched lots of them. My final question to everyone, what one big measure of success would you place on the 10-year plan and the upcoming cancer strategy to know that we're making the change needed? So what do you think is most important, or what one measure would you pull out? I know that's hard to answer, but there we go. Urmi, over to you first.
Thank you. I think to commit to the 62-day waiting time standard, and to really then ensure that patients get optimal treatment to improve cancer outcomes.
Adam.
I'm going to say two things, sorry. I welcome attention to the clinical trials and the setup of clinical trials within the long-term, the 10-year plan, because I think that a robust and progressive healthcare system will attract the latest treatments and trials moving forward, and that will be a surrogate of the success of the plan. And then finally, closing the gap on health inequalities, because that will improve outcomes. It not only improve outcomes from the most deprived and diverse communities, but it will improve the outcomes for all of our communities.
Wonderful, thank you. Leeanne.
Yeah, following on from Adam, tackling the disproportionate mortality rates from treatable cancers in Black and ethnic communities, addressing the systemic and cultural barriers that drive inequality, and improving early diagnosis.
Fantastic, thank you. Mike.
Agree with everything that's been said before, but I'll have to think of another one. But a very important one is, can we really see stage shift at diagnosis? So particularly, can we reduce the number of people with stage 3 and 4 disease? Because that's what kills most people. So if we can do that, we will know that we're going to have better survival 5 years down the track. So I'd have a lot of emphasis on stage shift.
Thank you. And Mike, you've done a lot of work over the years learning from other countries, in international comparisons, comparative analysis. Is there anything you think we should, we've learned a lot about early diagnosis, but anything else you see around the world that people are doing really well that we might be able to borrow or learn from?
Well, I think they do diagnose people earlier. Let's also remember that once people get to treatment, we have got variation in treatment across the country, and we've got to really eliminate that as well. I'm not saying any country's got that done perfectly, but we really need to focus on that as well as on the earlier diagnosis.
Fantastic, thank you. And that partly, of course, goes back to the data, having great data that we can share and understand. Thank you all. It's been fascinating, and I've really enjoyed it. And we could go on because there's lots more questions in the chat, but I'm afraid I'm going to have to wrap it up. I think a key reflection for me, which you've all talked about really powerfully, is both the end-to-end nature. So the 10-year plan talks about big shifts in models of care, but in order to treat our 2025 population. And so that's not just about treating a symptom or necessarily one particular illness, it's about treating the person. And therefore that's got to be rooted in communities. We've got to ask people what matters to them. And we've got to think end to end, yes, opportunities to prevent, but absolutely opportunities to live well with, taking in, community connections, making sure people feel well supported through journeys. I also think there's something that's come across really strongly about the ecosystem, this point about momentum and every part of the ecosystem being able to play a role. So thank you to our panel. Thank you to the audience for participating, and thank you also to our sponsor, MSD. We would love to hear what you thought of today's event, and you will have an email in your inbox linking to our feedback survey, which I promise is very rapid. If you missed anything or would like to share the link with colleagues, the event will be available to watch on demand on our website, and we hope to see you at another King's Fund event in the near future. So thank you, panelists. It's been a really interesting hour, and that's it from us.